Probably gonna be.
Okay, quick diagram of the heart. On the right side, you've got right atrium, right ventricle. Left side, left atrium, left ventricle. Have you done the heart yet in this room?
Yes.
Okay, so you're all up on it. You know everything there is to know about it. Okay. If we cut through the heart, you'll see 3 layers. The outside layer is called epicardium. Epi, outside, like epidermis. Okay, so that's the outermost layer. It's got connective tissue. Okay. The layer up against the heart itself is called parietal pericardium. And then on the very outside, you've got fibrous pericardium. This parietal pericardium, you can see from the picture, it's actually got 2 layers. And there's a space between those 2 layers. The space is going to have a little bit of fluid in it so that it slides when the heart beats. Okay, next, the middle section is the thickest. This is your muscle, myocardium. Okay, myo refers to muscle. And the innermost layer, very thin, you've got a lining there. The lining is made up of well, it's made up of cells called endothelium cells. Endothelium. This is going to be endocardium. Endo is inside. Okay, look at the words, they help. Okay. Now, there's really 3 types of muscle in the heart. Most of it, though, are going to be these contractile muscle cells. 99%. The other 1% is made up of specialized muscle cells that create the electrical current within the heart that allows it to beat on its own. Okay. Again, most of the muscle fibers are going to be made up of your, typical cardiac muscle. The typical cardiac muscle is going to be, I have a picture here. It's going to be striated. It's got a nucleus. Usually they say the nucleus is central. Sometimes it gets off center a little bit. They branch. They look a little bit like skeletal muscle, except they're shorter, much shorter, and they're branched. They are held together by structures called intercalated discs. Intercalated discs. Let me back up a little bit. Make sure we get through the slides. Bounded by sarcolemma. We've got myofibrils inside. It's going to be the same kind of myofibrils that we've seen in other muscle cells that actin and myosin. Just like skeletal muscle, it will have troponin and tropomyosin. It will create a similar sort of tropomyosin complex that we need to unlock from the actin. The intercalated discs are thickenings when you look at it under the microscope. But there's a lot going on in those little thickenings. Okay? It's a strong binding so that they don't tear apart when the muscle contracts. So they're bound together strongly. You've also got some of the adhering structure is going to be the desmosomes, but you also have gap junctions, which allow current to flow. Okay? Because current flows real easily between these muscle cells, you end up getting something that works as a unit. Right? The term that gets used is syncytium. There are T-tubules in there. The T-tubules are going to be a little different than what we saw in skeletal muscle, mostly because of the location. The T-tubules in skeletal muscle were at the AI junction. Those are the bands that we talked about, A band, I band. And in cardiac muscle, they're closer to the Z line. Okay? You can go through this table, but really, this is what I wanted you to know. The location is different. But they're there, and they work similarly. Okay, this is just a wording of things that I've already said. Any questions so far? Yeah.
So back up.
See anybody? No questions?
On the cardiac muscle histology, it shows that some of the muscle cells are able to have multiple nuclei. Is that something that actually happens, or is that just the image?
That is something that can happen. Yeah. Most of the time, it's going to be one nucleus. Occasionally, two nuclei. And whether or not that's due to fusion of a couple of muscle cells, I'm not sure. But the typical description is going to be one nucleus. But yeah, two nuclei, not unheard of. Okay. The organization of the muscles is a little odd. It's not the same as what we saw with organization of skeletal muscles, where they just form sort of straight fibers going down the muscle line. These fold and twist. Right? You can see the arrows are indicating the direction the muscle fibers are going. So think about what that's going to do to the heart when they contract. You know, it gets contracted from a few different directions and a little bit of a twist going on just to empty things out. I don't know if you have a tube of like lotion or something you're trying to get out, get that little last bit, you know, have to twist it a little bit, squeeze, top up. That's what the heart's doing, is trying to get as much blood out as possible. Yeah. Yeah, like you're draining out a toxin. Not fires. No fires, fibers. Hopefully no fires. Sorry about that. That one got by me. Excuse me. Now again, about 99% of the muscle cells in the heart are going to be the contractile cells. Okay? The ones that set up the electrical current or the conduction through the heart are modified muscle cells. You know, they're still considered muscle cells rather than neurons. Right? So you're going to find them in things like the SA node, the AB node, fiber bundles coming from those structures. They create their own rhythm or their own action potentials. So some go faster than others. And the way the flow ends up going is the faster ones sort of take over for the slower ones. But that's what sets up the rhythm. It's going to be the faster ones that set up the rhythm. The slower ones can keep it going. The faster ones set up the rhythm. Okay, those cells are known as pacemaker cells. They create the pulse of the heart. The fastest cells are going to be in the SA node. Conducting system of the heart. SA node is right here. Sinoatrial node is right next to the opening of the superior vena cava. It will send out signals that go through muscle fibers in the atrium, so the atrial syncytium. It also will send signals through junctional fibers. There will be 3 of them. I like how they sort of form a talon going toward the AB node. If you look at the name, it tells you location, atrioventriculars between the atrium and the ventricle. You then have your AB bundle, commonly known as the bundle of His, H-I-S. It will then split into branches. Now on this picture, they make it look like Purkinje fiber is part of the branch. It's my understanding, though, that Purkinje fibers are fibers that are within the syncytium of ventricles. Okay. So you have your branches, and they will go to Purkinje fibers and create a current going through the ventricle. Okay. Properties, electrical and mechanical. So you've got the specialized cells that have their own excitability. Some of the terms you might see used are bathotropic or tropic. We've got another dromotropic. But they help set up the pattern. You know, they describe, bathotropic describes changes in excitability. These specialized conducting cells create autorhythmicity. That means it's setting up its own rhythm. And it begins at those pacemaker cells, which were where? Where were the pacemaker cells? SA node. Okay. Dromotropic refers to conductive speed at the AB node. And then you have the mechanical part, the contractility. There is going to be a refractory period. We'll see that when we take a look at electrocardiogram. The staircase or treppy effect, that means as the signal continues, it gets more strong. It's like going up staircases until it hits an action potential. I don't think we see that in any of our pictures though. Resting membrane potential for these cells is about minus 85. Be careful about this one. It says nerve fiber minus 90. Okay, fiber, yeah, minus 90. But when we've been talking about nerves, we've been talking about cell body minus 70. Right? That's what I want you to know rather than the minus 90. So in skeletal muscles, it was about minus 90. Cardiac muscle, a little bit less, but close. Smooth muscle was way low, or way high, I guess, depending on how you're describing it. You know, much less negative, minus 55, minus 60. I think they can even get down to, or up to minus 50. Okay. This really isn't an EKG here. This is more of an electromyograph. So they stuck an electrode in a cardiac muscle cell to see how it responded. So this horizontal line is representing the cell membrane, sarcolemma. Sodium channels are going to open, so that sodium goes inward. This is called a fast channel. It opens and shuts pretty quickly, but it allows a lot of sodium to pour in. Well, that's going to create the potential, or cause the potential to become less negative. Okay? Overlapping toward the end, we get our calcium channels opening up. Okay, calcium, most of the calcium will be coming from the outside. There will be some calcium coming from sarcoplasmic reticulum, but a little bit like smooth muscle, most of it will come from the outside. That's going to create this little plateau. Right? We can see if we look at potassium, channels, they'll open, potassium also creates plateau. We want the plateau there because we want our contraction to be maintained until the blood gets out. And then we quick drop. Okay, those are the words. A couple other tables I thought I'd put up that I thought helped. So influx of sodium causes potential to rise. Those channels open and close quickly, so we reach our peak and they close. Okay. Slow calcium channels open. We have our plateau. slow calcium channels closed, voltage gated potassium open. We get to repolarize. Potassium channels closed, we're at resting. Okay, we've got a refractory period. And then below it separates it into absolute refractory, and then relative refractory. But at these points, you shouldn't be able to get your heart muscle stimulated again. The bottom two pictures compare skeletal to cardiac. One of my early instructors, my mentor while I was working on my master's degree, was from New Zealand, so I'm sort of used to calling it skeletal muscles. So if I fall back into that, that's why. So we've got skeletal muscle, cardiac muscle, small refractory period versus a large refractory period. Contraction is quick, contraction is long, slower. Okay, resting potential, about minus 90, minus 85, I think we've been going with. The actual potential is going to be 20. So that's quite a bit of change in membrane potential to get out. The threshold is about minus 55, minus 50. Autorhythmicity, and simply that's auto yourself, that's creating its own rhythm, like the one going through your head right now. Right? So, because of things like the SA node, the heart is able to create its own rhythm. Okay, you can cut off all the nerves surrounding the heart. Cut them all out. It's still going to beat, which is a little creepy. All right. The nerves that do attach to the heart, their job, the vagus nerve and the sympathetic nerve, their job is to increase or decrease the beat, but it's not causing the beat. So we say these are myogenic. They create their own contraction independent of nerve supply. Due to the specialized, really electrical cells within the heart that create the AV node, the SA node especially, that's the pacemaker SA. And then the fibers coming out, the junctional fibers, the bundle disc, the Purkinje cells, okay? They're all working together to create that beat. Okay, those cells were about 1% of the cardiac muscle to function pacemaker, set the rhythm, and the conductive system. By the conductive system, that's the junctional fibers. I mean, pacemaker, we say SA node. So everything else is the conduction system. So the junctional fibers, AV node, bundle disc, Purkinje cell. Right. They do not have a stable resting potential. Or at least it's not there for long because it's creating a rhythm. On our diagram, the red is the sinus normal fibers, so those are coming from the SA node. So you can see, they have their own little rhythm here. They're fast. They're going to affect the ventricles as the fibers run through that conductive system. So the green is the ventricular muscle fiber as it contracts. The rate of generation of action potential at different sites of the heart, SA node, about 70 to 80 action potentials per minute. Said that was fast. It starts at the fast one, goes slower. AB node, slower, 40 to 60. AB bundles and branches and Purkinje fibers, even slower, 20 to 35. See, this is what's giving it direction, the direction of conduction. And you're starting up at the atria, going down to the ventricles. Questions? Cheap seats, questions? Nosebleeds, right? At least you got in, There's people standing outside. Okay, the next one is the electrical system. A lot of that's going to repeat what we already just did. You might see a few new things. Okay. The picture is of a gentleman who won the Nobel Prize for being the first guy to measure electricity going through the heart. A galvanometer measures electricity. It was discovered before this guy. He was just one to do it for the heart. The first one, I think, measured or responded to nerve fibers in front lines. But we mentioned that there is directionality. There is direction. The conduction system starts at the base of the heart, which is the top, and it starts on the right side. Okay, where the superior vena cava is, where that SA node is. Then it goes medially down and around to apex. to point to the heart. Okay. Magnitude of reported voltage from the heart muscles is in proportion to amount of tissue being repolarized. You don't need to know the ins and outs of the galvanometer unless you want to. We saw this picture before. It goes through the conduction system, and again, this is where we're starting. The base is the top of the heart. On the right side, by the opening of the superior vena cava, here's our SA node. Right, that's the one that's setting everything up. It was one that had the fastest journey to AP. You know, it got its action potential faster than the other cells in the system. So it starts off at the SA node. We've got in the atrial syncytium. This is the cardiac muscle nerves themselves. Sorry, I had too much into nervous system. The cardiac muscle cells themselves, because of how they're set up and the intercalated discs, allows passage of ions very quickly from one cell to the other. So it allows it to spread very fast, and that's what they mean by syncytium. Okay. So not only are we getting the electrical signal going through the atrium just by way of the muscle cells, but we also have some bundles. Here they're calling it internodal pathways. The flow chart calls them junctional fibers. Those are the same. Going to the atrioventricular node, right there. Those cells are going to have their own action potentials that's a little slower from the SA node, but the SA node will help drive them. That rhythm from the SA node will help drive them. Okay. So the signal then travels down our AV bundle, or bundle of His, through the branches, into the Purkinje fibers, and then again, the muscle cells, because of the intercalated discs, are able to spread their potential very quickly, acts as one. Several cells acting as one. Ooh, we got 5 minutes, sorry. So SA, and again, a lot of this has been repeated. SA node, we talked about its location. It's up in the right atrium where the superior vena cava enters. It sets the rate. Okay? We can disconnect all the nerves, it will still beat. The nerves are just going to speed it up or slow it down. Initiates the P wave. AV node slows it down a little bit. Because it slows it down a little bit, what it's doing is it's allowing all of the blood from the atrium to empty into the ventricles. Corresponds with the early part of PR segments. Bundle of His, that's the AV bundle going down the interventricular septum. It will split into branches associated with the first part of the PR segment. Purkinje fibers They are within the walls of the ventricles, helping them to be. The ventricle muscle walls are thicker than the atria, so it does take a little longer for the muscle cells to spread the conduction, and so the Purkinje cells are helping with that. Okay, QRS complex indicates the ventricular depolarization. Height varies with the amount of myocardium, so depending on the part of the heart. Atrial repolarization occurs during this time, but the electrical signal is obliterated by the ventricle, does not affect heart rate. Okay, now here's what we're talking about. Here's from an electrocardiogram. Now we mentioned a P wave, QRS. Later on we'll have a T wave. Sorry, I got cut off there at the bottom. I like this picture. This is showing what's going on in the heart, how it affects that electrocardiogram. So we're starting off here where it says start. I always find that's a good place to start. SA node. That's the yellow on top, right next to the superior vena cava. If you look at purple, that's a part of the Purkinje. Okay, so it's sending signal out. And you can see if you look really close, it's turning purple around our SA node. Okay, that's your peak. The signal spreads. Okay, that's going through the atrial syncytium. Right. Look for the purple on the graph. Okay. Now we're getting our AV node and bundle involved. Those are QRS. Spread through the syncytium and ventricles. That's that little area between S and T. Okay. And then we get our T wave, more of the convection. Getting to wane, but more of it's there. Right. Compare the two. It's a little stronger. So that's your T wave. And then that brings back to the start. Okay, chart, speed, pacemaker, conduction, additional resources. This is a little video